Hello, can you hear me?
Yeah, clearly.
Hello,
Hello, Assalamu alaikum.
Walaikum salam.
Yeah,
I'm
you are
Dr.
audible.
Shaista Bilal. Yeah, I'm Dr. Shaista Bilal, mentor from MedPrep Online. So today, what we will discuss about the female genital tract, the anatomy of the female genital tract. So, how many of you have joined today?
11 up till now.
11. So that's great. So can you give me some introduction? I can
I'm Dr.
see,
Aisha Rahim.
and I can see Munira, Amina, Dr. Meena, Sana, Dr. Hira. So today, this is the agenda what we will discuss. The female reproductive system anatomy, the relations of the female genital tract to the other organs, and blood supply, nerve supply, lymphatic drainage, and somehow we will discuss about the applied knowledge in these clinical scenarios. So let's start with the first slide. All of you know that female genital tract, there are some internal organs and some external organs. So any one of you can enumerate about the internal genital organs?
Internal genital organs are uterus, fallopian tubes,
Yeah,
ovary, vagina,
yeah,
and
that's
external
great.
genital organ is vulva and vagina.
Yes. This is the slide. You can see this is the vulva. The vulva here, this is the clitoris, labias 2, labia majora, labia minora. This is the vaginal opening. This is the urethral opening and anal opening. Then these are the internal organs: uterus, fallopian tubes, ovaries, and cervix. And this is the vagina. Here you can see the external genitalia, commonly we call is vulva. This include the mons pubis, labia, clitoris, and vestibule structures. So first of all, we will discuss about what are the external genitalia. External genitalia include the mons pubis. The mons pubis, this is a fatty rounded area overlying the pubic symphysis. And after puberty, this area is covered with pubic hair. I know these all are the basic things. And all of you, maybe they must have remembered from their anatomy classes. But just we will take a quick review of all the things. This is major labia majora. Labia majora, they run posteriorly from the mons pubis, and they're two elongated hair-covered fatty skin folds, and they are counterpart of the male scrotum. They vary in size and distribution among females, and the size is dependent upon the adipose content. The labia majora, they have hair follicles, and anteriorly they unite to form the anterior labial commissure, and posteriorly they are separated by the posterior labial commissure. Now these are the labia minora we will discuss. They are two thin hair-free fold skins, and they are spongy tissue covered with blood vessels and sensory nerve endings. And anteriorly, the labia minora join to form the frenulum, and posteriorly, they combine together and they form the posterior faucet. The importance of labia majora and minora, sometimes when we discuss about the elderly patient, they came to you with itching, and they have lichen planus or lichen sclerosis. So labia minora, there is resorption of labia minora. So these are some clinical things which can come in exam regarding labia minora. There is figure of 8 lesion, and the treatment also depends upon what is the condition and how much means the patient is symptomatic. Hello, Iram. Hello, guys. Is everything clear up till now?
Yes, ma'am.
Okay. So moving forward, labia minora, this is about encloses a recess called the vestibule. This vestibule, they contain all these organs. Like on the sides of the vaginal opening are the P-side greater vestibular glands. These vestibular glands are homologous to bulbo-urethral glands in the males. And these glands release mucus into the vestibule to keep it moist and lubricated. This is again, we can see the bigger picture, mons pubis, clitoris, urethral office, vaginal opening. This is the anal opening. These are labia minora. These are labia majora. This is the mons pubis. Then again, the clitoris is anterior to the vestibule. It's composed of erectile tissue. It's richly innervated with sensory nerve endings, and it becomes swollen with blood and erect during tactile stimulation, and it's contribute to female sexual arousal. This has dorsal erectile column, so it's called corpora cavernosa, but no corpus spongiosum. Nerve supply is from the terminal branches of the pudendal nerve. That's an important question. So you should know the nerve supply of the clitoris. Then very important structure which is called the Bartholin gland. These are two bilateral compound glands, 0.5 to 1 centimeter. Here they are located, situated deep into the labia majora at the junction of the posterior and middle third. They are 2 centimeter long and opens between the hymen and labial minus. Bartholin glands, they are responsible for secretions during sexual excitement, and they have cells of endocrine function. They secrete serotonin, calcitonin, and HCG. So this is also important question. And this is important site for abscess formation or cyst formation. So this is also, you can see here, this is the Bartholin, gland. And here it comes with the abscess. So, and we should know that how the patient will present with the Bartholin abscess. They will present with the swelling at the level of the introitus or at the labia. And the patient will complain sometimes pus discharge, sometimes bloody discharge. Sometimes it would be only a cyst, or sometimes when it would be get infected, there will be abscess. Patient can present with high-grade fever. And the treatment is Mrcpch of the cyst. So that with Mrcpch, there is very less chances of recurrence. Otherwise, if you do simple incision and drainage, there will be more recurrence. And there are very less chances that there will be cancer of the Bartholin gland. But anyhow, if always need to send specimen for histopathology to rule out any cancerous changes. Then these are the skinous gland. There are two blindly ending paraurethral tubules that opens in the floor of the urethra. And the opening is 0.5 millimeter in diameter. And they are the counterpart. They are also called the female prostate. Now we will see about the external genitalia blood supply. The blood supply, they all from the branches of femoral artery, internal pudendal, external pudendal. And veins are external and internal pudendal veins. Here you can see these are the dorsal artery of clitoris, deep artery of clitoris, urethral artery, muscular branch, Bartholin gland, transverse perineal, internal pudendal, and inferior rectal artery. These all are very important, and you should all remember the name of the blood supply. Nerve supply, all these anteriorly come from the ilioinguinal and genitofemoral nerve, and posteriorly from the labial branch of perineal nerve, branch of the pudendal nerve, perineal branch of femoral cutaneous nerve of the thigh. So everything is clear up till now, guys. Hello?
Yes, ma'am.
So I know it seems to be very boring and very basics, but anyhow, we have to do it. And I don't want to make you more I want some interest, like you guys also, if you have any question up till now. Or is it clear?
Ma'am, skin is gland.
Yeah.
In England, resembles
What do
like
you
male
want
prostate.
about this?
Ma'am,
These are the skin is gland. You see, the location is, they are near the urethral opening here. These are the skin is gland here. Picture? Or I will zoom it. This is the urethra. Hello? Am I clear?
Urethral opening, external urethral opening.
Yeah, this is a urethral opening, and beside these, there are two skin is gland.
Yes. These are female
Okay.
prostate.
Yeah.
Yes,
Then
ma'am.
then we already discussed that nerve supply, lymphatic drainage. Lymphatic drainage is very important because when you know the lymphatic drainage of all the external genitalia, you will be well aware that if there is any cancer of the vulva or perineal area, where does the metastasis and which lymph nodes are involved. So it is very important to know. Okay. Especially you see that medial group of the superficial inguinal lymph nodes, then deep inguinal, then obturator, then internal iliac lymph nodes. When you will read the vulval cancers, their staging, inguinal lymph nodes, and deep, then obturator, then internal. It is very helpful if you know where does the lymphatic drainage go. Okay. Now comes, we will discuss the internal organs. This is a uterus. All of you are aware of it. This is the fundus. These are the two fallopian tubes. These are fimbrias. This is the ovary. This is the cervical part of the uterus. The hollow part, pear-shaped organ with thick muscular wall, and it measures around, in the young nullipara woman, is 8 centimeter long, 5 centimeter wide, and 2.5 centimeter thick. The uterus, these are the parts of the uterus, as I have already mentioned. This is the fundus above the entrance of the uterine tubes. These are two fallopian tubes. This is the body of the uterus, and this is the cervix. Cervix has two parts. One is the supravaginal, and one is the vaginal. It pierces the vaginal wall, and this is the interior of the uterus. This is the cavity is triangular in coronal section, and it is merely a cleft in the sagittal plane. Cervical canal communicates with the cavity of the body through the internal os, with the vagina through the external os. So this is the cavity. These are the two tubes, fallopian tubes, where it opens, and this is the fundus. This is all the muscular body, uterine wall. This is the internal os. This is external os. These are the posterior fornices, and this is the cervical canal. It's okay up till now here?
Yes, ma'am.
Yes, ma'am.
Okay. Now we will see that this is the cervix. In nullipara, the cervix is like, you can see from the picture, it is external os is circular. And in multipara, after deliveries, the cervix is almost transverse in shape with two leaves, anterior and posterior. So these shapes of the cervix, when we see from speculum examination, and these are the relations of the uterus. If you see the body, utrovesical and superior surface of the bladder, supravaginal cervix, superior surface of the bladder, and vaginal cervix is anterior surface of vagina. And post the uterus, we can see that there is a retrovaginal pouch where there's gut like ileum and sigmoid colon is there, and vaginal portion of the cervix, it's called the posterior fornix. These are relations we can see from the picture. This is the uterus. In front of the uterus, we can see here, this is the bladder. This is the vagina. And this is the posterior fornix. And this is the rectovaginal pouch. Here, this posterior rectovaginal pouch, we can see here the guts like rectum, ileum, sigmoid can be here. And anteriorly, there is bladder. And this is the utrovesical pouch. Laterally, the uterus, the body, the broad ligament, and uterine artery and veins. And supravaginal cervix, there are ureter. And supravaginal cervix, the lateral fornix of vagina. This is very important because while doing hysterectomy, you should know what clamps you are going to take and what ligaments and what structures, when you are doing clamp, the structure will come. Because here at the level of internal os, a ureter is there. And here along with the uterine artery and broad ligament. Then you can see the position of the cervix, anteverted, retroverted, anti-flexed. So these are just the position of the cervix. This is a retroversion or retroflex. In some women, fundus and body of the uterus, they are bent backwards on the vagina in the pouch of Douglas. And in this situation, uterus is said to be retroverted. If the body of the uterus is in addition, but backwards on the cervix, again, then we call it retroflex. So these are the normal variations, anteverted and retroverted. Structure of the uterus. Structure of the uterus, here, this is the inner lining, which we call as endometrium. This is the myometrium, the muscular wall. And this is the outer layer, which we call as the perimetrium. The myometrium, this is a thick muscular wall, and it's made of smooth muscles supported by connective tissue. Endometrium, mucous membrane lining of the uterus, and it is continuous above with the mucous membrane lining the fallopian tubes and below the mucous membrane lining the cervix. And supravaginal part of the cervix is surrounded by the visceral pelvic fascia, which is referred as a perimetrium. It is in this fascia that the uterine artery crosses the ureter on each side of the cervix. That's very important to remember. Now we will come to the blood supply of the uterus. The uterine artery is the branch of internal iliac artery. So this always remember. This can be a pet question, that uterine artery, from where it arises. The path is also very important, that it crosses ureter at right angle and reaches the cervix at the level of internal os. This is the ovarian artery. This is the uterine artery, and it reaches the cervix at around the level of internal os. Here, the ureter is also coming. This we will discuss later in our clinical applied anatomy. The artery then runs along the lateral margin of the uterus within the broad ligament and ends by anastomosing with the ovarian artery, which also assists in supplying the uterus. So uterus has two blood supply. One is from the ovarian artery branch and one is from the uterine artery. The veins follows the artery and drains into the internal iliac veins. Here you can see this is the aorta. This is the common iliac. This is internal and external. From internal iliac artery, this is the uterine artery. And uterine artery, here it reaches at the level of internal os. And here we can see there is a small cervical branch. This is the ovarian artery. It also it arises direct from the aorta. And here it supplies the ovary, and also it forms as part of the blood supply of the uterus. So is it clear up till now, guys?
Yes, madam, I have one question. Ovarian is a direct branch of aorta, but
Yeah.
On the right side, and the left side rises from left renal, no? Or it is
No. The vein supply is different. The arterial supply is directly from the aorta from both right and left artery. But I will discuss later with the blood supply of the ovary. So here your answer will be there. Okay.
Okay.
This is also very important exam question. So you should remember it. Okay. Then you see again, whenever we discuss the lymphatic drainage, it's always very, very important because all the metastasis, the cancers, they have lymphatic drainage, and we should know that which lymphatic nodes are involved by staging of any cancer, and we have to remove when we are doing radical hysterectomy or like this. So you can see from the uterus, the lymphatic vessels from the fundus of the uterus, they accompany the ovarian artery and drain into the para-aortic lymph nodes. So fundus, they drain into the para-aortic lymph nodes. And then later on at the first lumbar vertebra, the vessels from the body and cervix, they drain into internal and external iliac lymph nodes. So please, this slide is very important and you should remember it, okay? The nerve supply, the sympathetic and parasympathetic nerve supply branches from the inferior hypogastric plexus. Now, another important thing is support of the uterus. The one support is levator ani muscles, and second is condensation of the pelvic fascia, which form three important ligaments. These are the round ligament, broad ligament, and cardinal ligaments. All of these three ligaments, you should remember the insertion of the ligament, like round ligament. This is a remnant of gubernaculum. It runs from the fundus inferior and laterally to the labia majora, joining up the inguinal ligament above halfway through its course and carries with it a vascular supply. So please remember where it has insertion and where it arises from the fundus of the uterus. Then the broad ligament, this is a fan shape, means peritoneum, sweeping peritoneum that overlies the ovaries and uterus anteriorly. It has parts mesovarium and mesometrium. Mesovarium, that portion of broad ligament that suspends the ovaries in place. It comes out from the broad ligament, wraps around the ovaries and goes back to the broad ligament on the posterior wall. Mesovarium, that portion of the broad ligament that is associated with the uterus directly. Mesosalpinx, that portion of the broad ligament that directly overlies the fallopian tube. So these are the three parts. This also you should remember. The cardinal ligament connects the uterus at the level of the cervix. The uterus is covered with peritoneum except anteriorly, below the level of the internal os, where the peritoneum passes forwards onto the bladder. In pregnancy, what happens to the uterus? In response to estrogen and progesterone, uterus gets greatly enlarged, and by the third trimester, the fundus raises at the level of the ninth xiphisternum, and it increases in largely as you should remember that how the muscle they enlarge. It is as a result of hypertrophy. This is also very important. Hypertrophy of the smooth muscles of the myometrium, although some hyperplasia also take place. This is also an important exam question. Now coming towards the vagina. The vagina is a muscular tube that extends upwards and backwards from the vulva to the uterus. And its measurements are almost 8 centimeter and has anterior and posterior walls which are normally in opposition. At the upper end, the anterior walls is pierced by the cervix, and which projects downwards and backwards, and it forms a fornices. Anterior to the cervix is called the anterior fornix, and posterior to the cervix is posterior fornix, and two lateral are the lateral fornices. It is important to remember that the upper part of the vagina lies above the pelvic floor, and lower half lies within the perineum. Then interior of the vagina. The area of the vaginal lumen which surrounds the cervix is divided into 4 regions that I have already told you, that anterior, posterior, right lateral, and left lateral. The vaginal orifice in the virgin process is thin muscular fold called the hymen, which is perforated at its center. After childbirth, the hymen usually consists only of tags. And it's also very important, like some women, they present with the imperforate hymen, with the presenting complaint is primary amenorrhea. When at the age of menarche, their mother will or their other family members will bring that she is at the age of 12, 15, and still she does not start periods. Then the important question is you should ask cyclical lower abdominal pain. This is very important question to diagnose imperforate hymen. The girl, she will complain that because the uterus and ovaries, they are producing hormones, there is production of blood, but there is no outway for the blood. So blood is accumulated there. So am I clear?
Yes.
So if any question comes with cyclical lower abdominal pain, the girl present with primary amenorrhea. So the option would be imperforate hymen, or there will be transverse vaginal symptoms. Then here comes relations of the vagina. The vagina is closely related to the bladder above. This is very simple. All of you must have known it, that above anterior is bladder, urethra, posterior upper third is related pouch of Douglas, middle third is ampulla of rectum, the lower third is related to the perineal body, which separates it from the anal canal. And laterally, the upper part of the vagina is related to the ureter, middle part is related to the anterior fibers of the levator ani, and its lower part of the vagina is related to the urogenital diaphragm and the bulb of the vestibule. In this picture, we can see all the relation. This is the uterus, fallopian tubes, ovary. This is the pouch of Douglas. This is the utrovesical peritoneum and pouch. Above here, anterior to the uterus is bladder. Behind is rectum, and here anal canal, vaginal orifice, urethra, and this is the bladder. This is the clitoris. So blood supply of the vagina. This is also very important question. Like vaginal artery is a branch of internal iliac artery, and vaginal branches of the uterine artery and veins. And vaginal veins form the plexus around the vagina that drains into the internal iliac veins. Lymphatic drainage, upper third of the vagina drains external and internal iliac lymph nodes, and middle third drains into the internal, and lower third superficial inguinal lymph nodes. This also is very important, like vaginal cancers, if lower third involve only inguinal lymph nodes, upper or CA cervix, they will directly involve the external internal iliac lymph nodes. Nerve supply of the, again, it's inferior hypogastric plexus. Function of the vagina, all of you have known that definitely it's a part of the birth canal. It's a duct for the menstrual flow. And now comes to the ovaries. There are 2 in number, and almost size and shape of the ovary, they are 1.5 into 0.75 centimeter. And the ligaments, they are mesovirium, suspensory ligament of the ovary, and round ligament of the ovary. This we have already discussed. And ovary lie in the ovarian fossa. Ovarian fossa also is very important because this is the area where very important structures they lie. And during deep pelvic surgeries like frozen pelvis or endometriosis, there are high chances of having trauma to the ureter at that level. Okay. Hello?
Yes, ma'am.
Hello? It's okay? Yeah. And it's bounded by external iliac vessels above and internal iliac vessels behind. Can you please mute your voice? And these are capsules and ligaments of the ovary. The ovary is surrounded by the fibrous capsule, tunica albuginea. The capsule is covered externally by modified. This all you can read. This is not this slide will be available. Each ovary is attached to the back of the broad ligament by mesovirium, suspensory ligament, round ligament of the ovary, and variable position of the ovary. Usually the ovary, they lie in the rectovaginal pouch. During pregnancy, with the enlarging uterus, they are pulled up in the abdominal cavity. After childbirth, when the broad ligament is lax, the ovary takes up and variable position in the pelvis. Blood supply here, your answer. Who asked that question?
I asked it.
Yeah, you see, the ovarian artery arises from the abdominal aorta at the level of the first lumbar vertebra. And the veins, the ovarian veins drained into the inferior vena cava on the right side and left renal vein on the left side. Okay?
Understood. Yeah.
The nerve supply is from the aortic plexus, accompanies the ovarian artery. Lymphatic drainage, again, this is from the para-aortic lymph nodes at the level of first vertebra. Fallopian tubes, these are almost 10 centimeter long and lie in the upper border of the broad ligament. Each connects a peritoneal cavity in the region of the ovary with the cavity of the uterus. Parts of the fallopian tube, these parts are very important because it's divided into 4 parts: infundibulum, ampulla, isthmus, and intramural part. Infundibulum is the funnel-shaped lateral end that projects beyond the broad ligament and ovaries, and the free edge of the funnel, that finger-like process known as the fimbria, which are divided over the ovary, draped over the ovary. This is the infundibular part. This is the isthmus, this is the ampulla, and this is the fimbria. Blood supply is from the uterine artery, from the internal iliac artery, ovarian artery, from the abdominal aorta, veins that corresponds to the arteries, and limbs. Nerve supply of the tube, sympathetic and parasympathetic. Importance of fallopian tubes. They are important channel of transport for the sperms. They will for infertility cases, we need to rule out that the tubes are patent or no. There are 2 ways how we can see the patency of the tubes. One is the hysterosalpingogram and one is the lap and dial laparoscopically. And if the patient is having low risk, there is no other signs of infections, PID, or any other deep endometriosis, we can go for simple HSG and we can see the tubes are patent or no. So, and another important significance if the tubes is that ectopic pregnancy, there are very high chances and more 90% of the ectopic pregnancies, they are in the fallopian tubes. And lymphatic drainage of the tubes, internal iliac and para-aortic nodes. So, how was up till now, girls?
Nice.
Hello.
Understood.
Understood?
Yes. Yeah.
I know it's very boring. Yeah, so the urogenital triangle, now we will discuss this. There's a deep pouch, superficial pouch, perineal membrane. Deep is superior to perineal membrane, roof is pelvic fascia. And superficial compartment. Superficial compartment is between subcutaneous tissue and perineal membrane. These all structure of the superficial compartment. This all you should remember by heart. Clitoris, crura, vestibular bulb, ischio-cavernous, ischial-tuberosity, bulbospongiosis, superficial transverse perineal muscles. Muscles contain the superficial perineal pouch. Then perineal membrane. This is also triangular sheet in the anterior half of the pelvic outlet. Dense fibromuscular tissue, previously called urogenital diaphragm. The functions are support pelvic floor, contracts effect of the raised intra-abdominal pressure, and contracts effect of gravity. Perineal body. This is synonymous as central tendon of the perineum, located between vagina and anus. Attachments are perineal membrane, superficial transverse perineal muscles, bulbospongiosis, levator ani, coccyx. Then this is the posterior triangle. Posterior triangle contain anus, anal sphincter, levator ani, and ischiorectal fossa. This all anatomy very important while having episiotomies, perineal tears. So all questions can come from this. Ischiorectal fossa, laterally it is bounded by the pudendal vessels. It's called pudendal canal. Medially, facial covering the levator ani and external anal sphincter. Posterior is sacrotuberous ligament. Anterior is urogenital perineum. and floor skin subcutaneous tissue. Anal sphincter, external anal sphincter, superficial portion and deep portion. Internal anal sphincter, thickening of the circular smooth muscle, important during repair of the 3rd and 4th degree tear. So, how many tears do we have during normal delivery?
For perineal tear, 4th degree. 4 degrees are there. 1st, 2nd, 3rd, 4th.
Yeah. So this is also very important. You should know the degrees. Who can tell me what is the 1st degree tear?
1st degree, only the vaginal mucosa is involved.
That's great. And 2nd degree?
2nd degree, vaginal mucosa and the
Perineal muscle.
perineal muscle, superficial
skin.
perineal muscle.
And skin. It's same like episode. And 3rd?
3rd, it involves the internal sphincter.
External.
Sorry. Yeah,
External
sorry.
and internal both. External
yeah,
and
both.
internal both. Then we have
Both.
3A, 3B and 3C. 3A means 50% of external anal. Less than 50, then 3B is more than 50 and 3C is internal anal sphincters. Then 4th degree comes with the rectal mucosa. And another separate entity is buttonhole tears.
Yeah, buttonhole tears. Where only rectal mucosa, there is a buttonholing in the rectal mucosa.
Yeah. So very good, great. So it's very important to remember the classification and how to repair them. This we will discuss later on, okay? Then this is the pelvic floor. Demands of upright posture, support of pelvic structures, passage of fetus, opening of waist elimination, fibromuscular tissue, and visceral ligaments. The important is if there is weakness of the pelvic floor, the patient will present with prolapse. So what causes relaxation of the pelvic floor? What are the important things?
Birth trauma. The commonest cause is birth trauma when it is misconducted basically. So inappropriate application of forceps or
good size babies.
Delivery. Yeah, big size babies. Or patient being in prolonged labor for a long time with stress on the uterosacral ligament causing
then other contributing factors are like menopausal status and patient have a history of high BMI, connective tissue disorder, great, and like patient has chronic cough, constipation, and she is lifting more weights. So these all are other contributing factors. Then these are levator ani. Levator ani, most important muscles are puborectal, pubococcygeal, coccygeal, and the origin is posterior aspect of the pubic bone, fascia of the pelvic side wall and ischial spine, and insertion is perineal body, sphincter and coccyx, and constitutes pelvic diaphragm and surfaces covered by the fascia. This is the pelvic floor, puborectal and pubococcygeal most medial. Pelvic diaphragm is a U-shaped layer of the muscle. Opening end of the U is directed anteriorly. Urethra, vagina, and rectum. Now, another important structure, pelvic ureter. The ureter is very, very important structure to remember because it's most commonly damaged or whenever you know the anatomy correctly. So during procedures like laparoscopic hysterectomies, abdominal or vaginal hysterectomies, whenever you know the clear pathway of the ureter, only in that way you can avoid ureteric injuries. This is a retroperitoneal space of pelvic side wall contain pelvic ureter, internal iliac vessels, pelvic lymph nodes, obturator nerve. Total length of the ureter is 25 to 30 centimeter. Diameter is 3 millimeter. The abdominal and pelvic portions are almost equal, each in 12 to 15 centimeter long. This is a root of the pelvic ureter. In the pelvis, the ureter first runs downwards, backwards laterally along the anterior margin of the great sciatic notch. This is a great sciatic notch. This you can see the ureter. This is a yellow color. Runs downwards and backwards and laterally. These things are important to remember. Greater sciatic notch, anterior margin. Then, opposite to the ischial spine, it runs forward and medially to reach the base of the bladder. Then it comes medially to reach the base of the bladder, where it enters the bladder wall obliquely. Within the bladder wall, it narrows down, take a sinuous course, and opens into the cavity of the bladder and lateral angle of its trigone as the ureter orifice. A pelvic ureter, the relationships are the pelvic part of the ureter crosses in front of all nerves, vessels on the lateral pelvic wall. And this is the important point, near the uterine cervix, the uterine artery lies above and in front of it. It's highly important surgical relationship. Always remember water under the bridge means water, the ureter is under the uterine artery.
Uterine artery.
Uterine artery lies above and in front of it. So it means the artery is above, the ureter is below. So ureter contains urine, it remember water. So this is very important to remember. All of you guys, they understand it?
Yes, of course, doctor. Water on the bridge.
Hello, I cannot hear you.
Very clear, doctor, very
Hello?
clear. Very nice.
Yes, ma'am.
Okay, someone is talking, but
Yes, go
I
on.
cannot understand. It's not clear.
Yes, continue.
Okay, so next, sites of anatomical narrowings. The lumen of the pelvic ureter is not uniform throughout and presents 3 constrictions at the following sites. At the level of pelvic brim, where it crosses the common iliac, and at the uretrovesical junction, where the ureter enters the bladder, and at the ureteric orifice. The pelvic ureter, the supply is very important. Renal, ovarian, tract branches from aorta, internal iliac, vesicle, middle ureter, middle rectal, and uterine. So many blood supply. The pelvic ureter, venous drainage from the ureter drain into the veins corresponding same arteries like falling same veins. Lymphatic drainage, the lymph from the ureter is drained into the lateral aortic and iliac nodes. Nerve supply is from the T12 to L1 spinal segments through renal, aortic, hypogastric plexus. And the parasympathetic supply is derived from S2, S4 spinal segments and through pelvic splenic nerves. The afferent fibers travel with both sympathetic and parasympathetic nerves. Ureteric injuries. Overall incidence is almost 0.5 to 1% of all pelvic operations. Incidence varies from 0.4 to 2.5% for benign conditions as reported in different studies, but it can be as high as 30% in operations for malignancies. 75% of ureteric injuries occur during an abdominal gynecological surgeries, which includes 0.5 to 1% of abdominal hysterectomy compared with 0.1% of vaginal hysterectomy. So all of you need to remember these data, okay? Incidence. These are the sites which are vulnerable for ureteric injury. At the level of pelvic brim, during ligation of the infundibulopelvic ligaments. This I told you, this is the very important like ovarian fossa, that area here. The first vulnerable site is this. This is only during very deep endometriosis or malignant surgeries for any malignancies. At the base of the broad ligament where it passes beneath the uterine artery, as it passes through its tunnel into the cardinal ligaments along the course of the lateral pelvic wall just above the uterosacral ligaments, at the anterior fornix of the vagina as it enters the bladder, and where it travels through the musculature of the bladder and lateral pelvic side walls of the iliac vessels during lymph node dissection. Any congenital malformation, example, duplex ureter, make it more vulnerable to injury at any of these sites. This is the pelvic ureter course. These are the nature of the ureteric injuries, like there could be simple kinking, angulation, ischemic injuries, ligation with the suture, crushing injury, transection, segmental injuries, thermal injuries, and injuries by staplers. These are gynecological procedures associated with ureteric injuries, like with abdominal, with vaginal, and with laparoscopic. With abdominal, during hysterectomies, Verdyne hysterectomy, oophorectomy, uterine suspension, vesico-vaginal fistula repair. Vaginal hysterectomy, anterior colporrhaphy, cervical biopsy, vesico-vaginal fistula repair, laparoscopic hysterectomy, colposuspension, endometriosis, and sterilization, especially when you use electrocautery. Prevention is better to anticipate the ureteric injury whenever you are going to do difficult procedures, involve urologist, MTT involvement, and pre-op intravenous urography, placement of the ureteric catheters, and ureteric catheters with incorporated light source. So very important. Then prevention during abdominopelvic surgery, adequate exposure, most important surgery, an important structure at risk of inadvertent injury must be carefully dissected and adequately exposed to avoid blind clamping of the blood vessels, to not damage the sheath of ureter, longitudinal vessels recognized by pale glistening appearance, longitudinal vessels on surface, and peristalsis. This is how you will recognize the ureter. Whenever you will touch it, there are peristalsis in the ureter. Key points for ureteric injuries: thorough knowledge of anatomy of the ureter is must, and to be aware of the sites where it is liable to be injured. Preoperative IVU or stent placement have not been shown to decrease the incidence of ureteric injuries. A high index of suspicion and early investigations are necessary for diagnosis. Early diagnosis and management will reduce postoperative morbidity and save renal loss. Timing of repair should be individualized as no difference in outcome in early and late repair. So that's it. Any questions?
Ma'am, can you explain about the ovaries when you described that it is bounded by the internal and external iliac arteries?
Dr. Excuse me, can you repeat how can I recognize ureter injury during cesarean section?
This we discussed ovarian fossa here. You can see the picture.
Yes, ma'am.
Yeah, this is the ovarian fossa. This one. This is the pubic bone. These are the muscles. This one is coming ureter, that blue one. Okay. This is the uterine artery. Ovarian.
Okay, ma'am.
And here, this is the common iliac. Okay. This common iliac, this is external iliac. This is internal iliac. Here,
Okay,
branches
ma'am,
from the
understood.
internal iliac. Now, here, this is external iliac vessel. These are the internal iliac. So here, this is the iliac fossa. Here, you see the ureter is also coming from here.
Yes, ma'am, it's clear.
Clear? Okay.
Yes, ma'am, thank you.
Welcome. Any other question? So can you give me feedback of the session?
Ma'am, it's well explained.
Thank you so much. Hope we are having our session will start, our course for preparation for the part 1 will start from the next Sunday. So hope, anyone have you joined the course?
Yes, ma'am.
So I will appreciate if I'm looking forward that all of you will join and we will help you. And I want to see all of you to pass with flying colors. So these are the contact numbers of our MedPrep Online, email ID, contact numbers, and very happy good evening to all of you, and thank you so much.
Okay, thank you, ma'am.
Thank you. Bye. Good evening. Bye.